Hello, nursing fans. We are covering Chapter 7 from Concepts or MedSurg today. So this is entitled Nursing Care of Patients Receiving Intravenous Therapy. I am on page 71 of the Understanding Medical Surgical Nursing, 6th edition. Mrs. Brown, 85 years old, is admitted to the hospital with weight loss of 6% of her total body weight due to gastroenteritis and diarrhea. Her blood pressure is 102/80, pulse is 96 beats per minute, and respirations are 14 per minute. Her physical assessment shows decreased skin turgor over the sternum, dry, cracked lips, and a weak, thready pulse. The healthcare provider, HCP, has ordered an intravenous administration of 5% dextrose and 0.45% sodium chloride to be started at 100 milliliters per hour. As you read this chapter, reflect on the challenges of fluid volume deficit in older adults and initiation of infusion therapy. Intravenous IV therapy is the administration of fluids or medication via a needle or a catheter, also called a cannula, directly into the bloodstream. Each state's Nurse Practice Act governs the practice of IV therapy in that state. Some states' Nurse Practice Acts now include IV therapy within the licensed practical nurse / licensed vocational nurse role, which is exciting. The Infusion Nurses Society, INS, is recognized as a global authority in infusion nursing and publishes standards of practice for infusion therapy. The INS 2016 standards of practice address the infusion-related scope of practice for LPNs and LVNs. The Centers for Disease Control and Prevention, CDC 2002, provides guidelines for isolation precautions, hand hygiene, and prevention of intravascular catheter-related infections. The Institute for Health Improvement, IHI, provides information related to central line care. The National Institute for Occupational Safety and Health, NIOSH, oversees workplace safety, including safety issues related to IV therapy. The American Society for Parenteral and Enteral Nutrition, ASPEN, provides sources related to IV nutrition. There's a learning tip on page 71 that states, national organizations provide guidelines, but you must look at your state Nurse Practice Act to decide which of those guidelines apply to you. As a side comment, that's easy when you live in a large state like Texas or Alaska, but when you live in New England and you possibly could be working at any number of states, because I've lived here 7 years, I've already worked in 3 different states. Not as a nurse though, but when I do so as a nurse, it is going to be my responsibility to know the standards for each state where I'm working. So page 72, indications for intravenous therapy. A variety of substances can be administered via IV therapy, including fluids, electrolytes, nutrients, blood products, and medications. Why do patients receive IV therapy? Many medications are faster acting and more effective when given via the IV route, because it's actually skipping over the GI tract and going directly into the blood, so it can get to the destination faster that way. And fast action is especially important in an emergency. Medications can also be administered continuously via IV to maintain a therapeutic blood level. Patients with anemia or blood loss can receive life-saving IV blood transfusions. They've also found that to be helpful with people with COVID. Patients can receive life-sustaining fluids, electrolytes, and nutrition via IV when they are unable to eat or drink adequate amounts. Patients who are unable to eat for an extended period can have their nutritional needs met with parenteral nutrition. The term parenteral refers to any medication route other than the digestive tract. There are 4 primary administration modes for IV medications. 1 is continuous, 2 is intermittent, 3 is direct injection / IV push, and 4, patient-controlled analgesia. Continuous infusion. A continuous infusion is a large volume infusion of solution or medications, typically 250 to 1,000 milliliters, administered over 2 to 24 hours. For a continuous infusion, the HCP orders the infusion in milliliters, ml, to be delivered over a specific amount of time, such as 100 ml per hour or 1,000 ml over 8 hours. The infusion is kept running at the prescribed rate until ordered to be discontinued. Now this chapter has a number of orange boxes that say, be safe. I'll just read the 3 that are on page 72. So, be safe, be vigilant, always verify that orders are complete and understandable. If you have any questions, contact the registered nurse, healthcare provider, or pharmacist. Another box says, be safe, be vigilant. Each time a primary intermittent set is disconnected, the tip of the tubing must be kept sterile using a sterile end cap. The intermittent cannula is flushed with saline or heparin to keep it patent while it is not in use. And keeping it patent means that keeps the tubing able to flow with no blockage. So a patent tube is fully usable and open with no blockage. Another box says, be safe, be vigilant. The medication in the piggyback tubing must be compatible with any other solution that is in the primary intravenous bag. Check with your pharmacy for compatibilities. Okay, now I'm going to go back and finish reading about continuous infusion. Continuous infusions are used when a medication must be highly diluted. A constant plasma concentration of a drug must be maintained, or a large volume of fluids and electrolytes must be administered. Rate control is important in the delivery of continuous infusions. It can be achieved by using an electronic infusion device, an EID, a mechanical controller, or a roller clamp. Intermittent infusion. Some IV medications, such as antibiotics, need to be infused over a short period of time. For example, an antibiotic may be mixed with 50 to 100 milliliters of 5% dextrose or 0.9% sodium chloride and infused over 30 to 60 minutes. This is often done as an intermittent infusion. As with any IV therapy, the HCP orders must specify the route, drug, dose, and amount to be infused over a specified time. Because certain things do need to be infused quickly, as I mentioned, such as antibiotics. But other things, it is important not to infuse them quickly, such as the electrolytes. In certain situations, you don't want to overwhelm the body. So, primary intermittent infusion. Intermittent medications and solutions can be delivered using primary intermittent administration tubing that is connected and disconnected with each use. Access to the bloodstream can be provided by a short peripheral vascular access device, sometimes called a saline lock, in which an IV cannula is inserted and covered with a sterile needleless cap or valve that seals after each use. I wish I had one to show, but I don't have one of those. But maybe later I'll have to show you some of the things that I do have. A piggyback or secondary intermittent infusion. If the patient already has a primary infusion IV, primary continuous IV infusing the antibiotic, secondary infusion can be piggybacked into the primary IV line. This piggyback set is left attached to the primary administration set. For the piggyback medication to infuse, it must hang higher than the primary infusion, which you can see on this picture on the PowerPoint. Piggyback medications can be infused using an EID, a mechanical controller, or a roller clamp. Needleless connectors. Needleless connectors are devices that allow connection to IV catheters, such as piggybacking into a primary IV line, administration sets, and syringes without using a needle. They are important for avoiding needle stick injuries in nurses. That's a big problem that we always need to be aware of anytime there's a needle around. Other terms used to describe such connectors are injection cap, port, or injection valve. The hub or extension set of a peripheral cannula that is covered with a needleless connector is sometimes called a saline lock. And they show one in 7.2, but I don't see one on our, well, actually, I think that there's one. This one looks similar to one over here. Let's see. Okay, this is one right here. This is figure 7.2. So this actually shows a peripheral IV with a needleless connector attached to extension tubing. So the needle's already in the patient, so all we will need to do is attach another tube to this, and then it can infuse into the patient. So the patency, oh wait a minute, intermittent IV lines can be capped off with a needleless connector, and this makes them available for intermittent or emergency access. In addition, because the needleless connector does not have to be removed to allow access, a sterile closed infusion system is maintained. The patency or unobstructed flow of intermittent cannula must be maintained by flushing at periodic intervals based on institution flushing policy and procedure. Always check for patency of an intermittent device before administering a medication, because any even new devices could be clogged. It's highly unlikely, but after the device has been used, Now, there are solutes in what we are administering that can linger in the tubing and build up, causing a blockage, which could be very serious for a patient. So we will have to maintain it by flushing at periodic intervals based on institution flushing policy and procedure. So not only are we checking to see what the standards are in our state, but each institution has a different set of policies and procedures that we are responsible for knowing and following. So always check for patency of an intermittent device before administering a medication. Do this by first scrubbing the hub. So yeah, this, you can see how this could become contaminated, so you want to scrub it. Attach the syringe and draw back to check for backflow of blood. If the blood is seen in the syringe, the catheter is patent. Once the patency is confirmed, flush with normal saline, which would be 0.9% sodium chloride. To maintain patency of a cannula, flush the cannula after each use or at least every 12 hours, if not in use or according to the institution policy. In addition to ensuring patency, flushing with saline also prevents the mixing of incompatible medications and solutions, because it's going to allow you to rinse one out before you introduce a new one. The INS recommends the use of sodium chloride for maintaining peripheral intermittent devices. Heparin, an anticoagulant, is recommended for flushing central venous access devices, CVADs. Remember that heparin is a medication and may be incompatible with other medications. Check your institution's policy for specific guidelines. We have another Be Safe box. It says, be vigilant, scrub the hub for 10 to 15 seconds using friction before each access to prevent infection. Positive pressure must be maintained in the lumen of the cannula during administration of the flush solution. This prevents a backflow of blood or solution into the cannula lumen, which could lead to an occlusion. Positive pressure maintains a closed infusion system within the needleless connector. If resistance is met while a cannula is being flushed, a clot may be occluding the cannula. Do not exert pressure on the syringe plunger in an attempt to restore patency. Doing so may dislodge the clot into the vascular system or rupture the cannula. Now, I've not seen the rupturing occur, but they're saying that that can happen. Be safe, be vigilant. Always check for cannula patency and follow the manufacturer's guidelines for use before injecting any substance into the circulatory system. Forced flushing could cause a clot to dislodge from the cannula into the patient's circulatory system. So now we've mentioned that you have to follow the rules that each state has established, and you also need to follow the policies of your institution. Now the book tells us that we have to read something else, which would be the manufacturer's guidelines for use. So when you see this I don't see who made it. I don't see a brand name on the picture here. But when this was opened, there was an instructions for use that came with it. And the instructions for use, I'm pretty sure, was painful to look at. It's never easy on the eyes. There's an opportunity to improve. Maybe some of them are getting better, but it's kind of like those inserts you get when you pick up drugs from the pharmacy because the print is too small. It's just, and there's a lot of it. But in this case, we're being advised to follow the manufacturer's guidelines for use, or instructions for use is what they're really called, before injecting any substance. So that's a lot of reading that we have to do. That's not always practical, but keep that in mind that it does exist, and we are responsible for knowing what all of those things say. Okay, direct injection slash intravenous push. So an IV push or direct injection medication is injected slowly between 1 and 10 minutes via a syringe into an IV port or IV site or port. An IV push provides a rapid effect because it is delivered directly into the patient's bloodstream. IV push drugs can be dangerous if they are given incorrectly. A drug reference should always be checked to determine the safe amount of time over which the drug can be injected. So now I've just asked you to read something else, and there's a possibility that reading about the drug is also going to be in somewhere with a lot of small print, but we are responsible for that. Now, IV push drugs are usually administered by registered nurses. I know a lot of us intend to pursue the RN license, so we need to know all of this. So, but IV pushes, they are not within the scope of practice of the LPN/LVN in some states. However, be aware of the drugs being given so you can assist in observing the patient for desired or adverse effects. Because when you're doing the push, it is a rapid injection, and that can make a significant change in the body's physiological response that we are responsible for watching for that. So you want to remain with the patient to make sure there's no adverse effects. So patient-controlled analgesia, PCA, is used to deliver analgesic or pain medications. An EID or pump is used to deliver the analgesic drug. The EID is programmed to administer a prescribed amount to the patient when the patient presses a button. The PCA administrations are usually done by RNs. They may not be within the scope of practice of the LVN or LPN. I guess it depends on the state, okay? So verify with your state nurse practice act to determine whether PCA administration is within the LVN LPN scope of practice. Again, be aware of the drugs being given so that you can assist in observing the patient for the desired or adverse effects. And I don't know what the rules are in Massachusetts, but I'm just guessing that LPNs are not allowed to do that in this state. Okay, methods of infusion. Gravity drip. So a gravity drip means there's no pump involved, okay? So gravity can be used to administer a solution into a vein, okay? See figure 7.1. Where's that one? Oh, that's the one I'm showing. Okay, good. This page just fell out of my book, so I hope everyone else's book is better than my book, because that has not happened in the past, and this is an expensive book. So the solution is positioned about 3 feet above the infusion site. We need to know that, okay? That is important. It definitely could be on the NCLEX. If it is positioned too high above the patient, the infusion may run too fast. If it is positioned too low, it may run too slowly. Flow is controlled with a roller or screw clamp. A mechanical flow device can be added to achieve a more accurate delivery of fluid. These are the factors that affect the flow, the change in the catheter position, the height of the solution. We need to target 3 feet as the height that we would want on these IVs. And then, of course, the patency is going to be important. So now we're going to go into calculating administration rates. And this is so important. This is why we have to do well on our math, because patients' lives depend on it. So when using a gravity set, you must calculate the infusion rate and or the drops required per minute to deliver the fluid at the ordered rate. Okay? Commercial parenteral administration sets vary in the number of drops delivering 1 milliliter of fluid. So sets typically deliver 10, 15, 20, or 60 drops per ml of fluid. Check the label on the administration set to determine how many drops per ml, which is known as the drop factor, are delivered by the set. Okay, sets delivering 10, 15, or 20 per ml are called macro drop sets. And these are used for fluids that need to be infused more quickly. Sets delivering 60 drops per milliliter are called micro drop or mini drop sets. And these are used for solutions that need to be infused more slowly. To determine the drops per minute for IV solution delivery, the nurse needs to know the amount of fluid to be given in a specified time interval and the drop factor of the administration set to be used. The formula for determining the drops per minute is, let's see if they're showing it here. I didn't really show the formula. And I hate to read out the formula, but I guess this shows it pretty well. In the book, they're showing a figure like this, but without the 1,000 and the 6 and the 10. Okay, so we'll just read this. Okay, so here's a learning tip. Always round to the nearest whole number when calculating drops per minute. You can't deliver a fraction of a drop. So a drop is the smallest that we can go on these. And so the formula for determining milliliters per hour is shown on the bottom of page 74. And it's the total number of milliliters divided by the total number of hours. So that's going to give you your milliliters per hour. So the book has a sample problem. Let's say you have 125 milliliters of 5% dextrose and a 0.45% sodium chloride per hour. You need to administer 1,000 milliliters, which is 1 liter, of 0.9% sodium chloride over 6 hours. So that's an isotonic solution at 0.9% sodium chloride. And you have a tubing with a drop factor of 10. So it's a whole liter. We've got 6 hours to get it into their veins. So how many drops per minute are we delivering? That is calculated by, so the 1,000 ml over 6 hours with a drop factor of 10, you're going to have the 1,000 over 6 hours, and then you're multiplying that by the 10. But because we need the hours converted to minutes, we do need to have the 60 minutes on the bottom of the equation. So the answer is 28 GTTS for that one. In the book, they're showing an example, normal saline of 1,000 milliliters over 8 hours. If you want to know what it is per hour, you're just going to do 1,000 milliliters divided by 8 hours. And each hour, our patient will be receiving 125 milliliters. Okay, so factors affecting the flow rates of gravity infusion. So there's a number of things that can affect it, and they're shown on this slide. So a change in the cannula position. You know, so if your patient moves around, a change in the position of the cannula's tip can affect the infusion flow rate. If the bevel, which is the slanted opening of the cannula, that's the very tip of the needle, is against the wall of the vein, the flow rate will decrease. If it is away from the wall of the vein, the flow rate will increase. Well, we can't really see inside the vein how close it is to the wall of the vein, so we need to become familiar with what gives adequate flow by just looking at the outside where it is placed. So placement of a peripheral IV or PIV in a joint area, which would be the wrist or the elbow, it can cause a kink in the cannula or a change in the tip position. So this can cause a change in the flow rate. Securing the cannula carefully and avoiding areas of joint flexion will minimize this problem. Patients need to be reminded to keep the flexion to a minimum when the IV is placed near a joint. So, where was that picture? This, trying to find it here. So, that's why this is taped to the patient, because we found a position where we feel that the needle tip is not up against the vein wall, and it's also, you can see this is not put in near any joint, so we don't have to worry about the patient flexing and affecting the positioning of the needle. Be vigilant. If the only usable vein is in an area of flexion, secure the peripheral IV appropriately and remind patients to keep flexion to a minimum. You'll need to closely monitor the PIV site and the flow rate while it's being used. Okay, so back to the things that affect it. The height of the solution. Because infusions flow by gravity, a change in the height of the infusion bag or bottle or a change in the level of the bed can increase or decrease the flow rate. The flow rate increases as the distance between the solution and the patient increases. They really mean that the height. A patient may inadvertently alter the flow rate greatly by simply standing up. The ideal height for a solution is 3 feet above the level of the patient's heart. So that's going to be important to remember. You know what a yardstick looks like? That's 3 feet. So we need to try to calibrate our eyes so that we can accurately place the height, because it does affect the flow, and how quickly the medication is delivered to the patient can affect the patient's well-being. Also, the patency of the cannula. So a small clot or a fibrin sheath can occlude the cannula lumen and decrease the flow rate or stop the flow completely. A fibrin sheath begins developing within the first 24 hours of the cannula insertion. Clot formation can result from irritation, vein wall injury from the insertion or the tip position, increased venous pressure, or a backup of blood into the cannula. So you're going to avoid the use of a blood pressure cuff on the affected limb because of the resulting transient increase in venous pressure. A regular flush schedule helps maintain patency. So they said we have to flush these at least every 12 hours. So it does seem like it's a good idea to have a schedule for that. Okay, I'm on page 75 now. Be vigilant, be safe. Never, never exert pressure with a saline or heparin flush in an attempt to restore patency. So you have to be very gentle and ginger in handling this. So you want to flush it, but not forcefully. It should be very easy to clear anything out. You should get flow very easily with no effort. So, because if you do apply any pressure, that could dislodge a clot into the vascular system or rupture the cannula, which would be very messy and you would have to start over. So we don't want to do that. So now there are mechanical and electronic infusion devices. So this is kind of like a dial-a-flow type of device. My notes in my book state that the mechanical infusion devices are not very precise. So the electronic infusion devices are going to give you more precision. I'm just skipping through the slides to see if they have anything here about the infusion devices, but they really don't have a lot. So let me get back up to where it was. Where did I see something about that? Okay, there's a picture of one. All right. Um, Flow control devices such as EIDs, which are electronic infusion devices, and mechanical controllers, which don't require electricity. Okay, that's why you may see those depending on what institution you're at, or the needs can dictate the need for one of those. These are going to regulate the rate of infusion, and they are used in all healthcare settings. See figure 7.3, which is the one shown here. Mechanical controllers measure the amount of solution delivered and depend on gravity to deliver the infusion, which is not a problem because gravity is the same everywhere on Earth. But if you do have to go into space, bear in mind that could be a little variation on your flow. So EIDs, sometimes called pumps, use positive pressure to deliver the solution. Pumps and controllers are used for infusing precise volumes and rates of solution. Institution policy often dictates the use of controllers for infusion of potent medications such as heparin, concentrated morphine, and chemotherapy solutions, and very fast or slow rates. Some EIDs are portable and designed to be worn on the body. These are called ambulatory infusion devices. It is important to know the type of pump being used and to follow the manufacturer's guidelines. Which I don't know how convenient those guidelines are, but I guess we'll find out when we get there into our clinical rotations. So filters can either be an add-on. They can be add-on devices to administration sets or built into the set during manufacturing. Various types of filters are available. The INS standards address the use of inline filters to remove bacteria, fungi, particulate matter, air, and some endotoxins from IV fluids. Check institution policy and manufacturer's guidelines for the use of filters. Types of fluids. So there are 3 basic types of IV solutions: isotonic, hypotonic, and hypertonic. See chapter 6, which we just covered. Fluids and electrolytes administered via the IV route pass directly into the plasma space of the extracellular fluid compartment. They are then absorbed based on the characteristics of the fluid and the hydration status of the patient. The most commonly infused fluids are dextrose and sodium solutions. These are called crystalloid solutions. So I'm thinking that crystalloid solutions are solutions that sound like they might be able to clog my cannula or my tubing. So that's why flushing is important. So dextrose solutions. Dextrose in water is available in many concentrations: 2.5%, 5%, and 10%. It is typically used for continuous peripheral infusions. Concentrations exceeding 10% and above must be infused via a central line into a large vein. So the advantages of dextrose solutions are as follows. They provide carbohydrates in a readily usable form for energy, reducing the breakdown of glycogen and catabolism of protein to help prevent negative nitrogen balance. They act as a means for administration of medications. High concentrations can be used for treating hypoglycemia or in combination with parenteral nutrition because they supply a large number of calories. Now, the disadvantages of dextrose solutions are as follows. Okay, vein irritation, damage, and thrombosis can result when hypertonic dextrose solutions are administered in a peripheral vein. Sodium chloride solutions. Sodium chloride solutions, which that's salt, are available in concentrations of 0.25%, 0.33%, 0.45%. All of those are hypotonic, so they're a little bit lower than what the natural normal saline in the body, which is 0.9%. So 0.9% would be isotonic, and the others listed are 3% and 5%, which those are going to be hypertonic because they have a greater amount of saline than normally occurs in the body tissues. Advantages of sodium chloride, sodium chloride 0.45% and 0.9% are used most commonly. So we know why the 0.9% is used because that's what our body likes, because it's the same tonicity as the fluids in our body. So advantages of sodium chloride solutions are as follows. They are useful for fluid replacement, treatment of shock, hyponatremia, and metabolic alkalosis, as a primer for blood transfusions, and during resuscitation after trauma. According to the American Association of Blood Banks, blood component administration sets can be primed only with 0.9% sodium chloride solution. That is very important for us to know as nurses, that when there's blood involved, you can't use any other saline other than isotonic. Combination dextrose and sodium chloride solutions, such as 5% dextrose with 0.45% sodium chloride, often referred to as D5.5, are commonly used for hydration and to check for kidney function before administration of potassium replacement therapy. So the disadvantages of sodium chloride solutions are as follows. They can cause circulatory overload if the prescribed rate is not monitored. If the patient is unable to excrete excess sodium, e.g. because of kidney disease or hormonal imbalance, hypernatremia can result. And acidosis can occur with continuous infusions. So balanced electrolyte solutions. Electrolyte solutions are used to replace lost fluids and electrolytes. A variety of balanced electrolyte solutions are available commercially. Maintenance electrolyte solutions, such as lactated Ringer solution, supply normal body electrolyte needs. Balanced solutions often contain lactate or acetate yielding bicarbonate, which helps combat acidosis and provides a truly balanced solution. Potassium is an electrolyte that is commonly added to balanced solutions to replace potassium deficits. The patient must be monitored for signs and symptoms related to potassium imbalance. See Chapter 6. So I'm on page 76 now. There's actually 4 Be Safe boxes on this page. So be safe, be vigilant. Be sure to review institution guidelines for potassium administration before administration of potassium-containing solution. An inappropriate rate or amount can cause life-threatening cardiac arrhythmia, which we don't want to cause that. So be safe, be vigilant. Since isotonic solutions expand the extracellular fluid volume, be vigilant for signs of fluid overload when infusing isotonic solutions. Be safe, be vigilant. Hypotonic solutions, because they enter cells, can worsen hypotension. They can cause cardiovascular collapse and increase intracranial pressure. So we have to carefully monitor these patients. Be safe, be vigilant. Monitor the patient receiving hypertonic solution for circulatory overload. Okay, so osmolarity of intravenous solutions. The osmolarity of an IV solution refers to its osmotic activity. As noted previously, IV fluids may be classified as isotonic, hypotonic, or hypertonic. Isotonic fluids have the same concentration of solutes to water as body fluids. Hypertonic solutions have more solutes, so they are more concentrated than body fluids. And hypotonic solutions have fewer solutes and are less concentrated than body fluids. So water moves from areas of lesser concentration to areas of greater concentration. Therefore, hypotonic solutions send water into areas of greater concentration, and hypertonic solutions pull water away from cells. So isotonic solutions. Normal saline 0.9% sodium chloride solution is an isotonic solution that has the same tonicity as body fluid. When administered to patients requiring water, it neither enters cells nor pulls water from cells. It therefore expands the extracellular fluid volume. A solution of 5% dextrose in water, D5W, is also isotonic when infused. However, the dextrose is quickly metabolized, making the solution hypotonic. So we have to remember that prior to administering it is isotonic, but as soon as that sugar hits the bloodstream, the body starts using it up, and the result of that is actually an hypotonic effect. The solution is going to be hypotonic. So lactated ringers and 5% albumin are other examples of isotonic solutions. Now, isotonic solutions commonly treat dehydration, fluid loss, and hyponatremia. Hypotonic solutions, hypotonic fluids are used when fluid is needed to enter the cells, as in the patient with cellular dehydration. They are also used as fluid maintenance therapy. Examples of hypotonic solution are dextrose 2.5% water and 0.33% or 0.45% sodium chloride solution. Hypertonic solutions, examples of hypertonic solutions include 5% dextrose in 0.9% sodium chloride, 3% sodium chloride, calcium chloride 10%, 5% dextrose in lactated ringer solution, 10% dextrose in water, and albumin 25%. Hypertonic solutions are used to expand the plasma volume. For example, in hypovolemic patients, okay, so they are also used to replace electrolytes. Intravenous access. IV therapy can be administered into the systemic circulation via the peripheral or central veins. Peripheral veins lie beneath the epidermis, dermis, and subcutaneous tissue of the skin, and they usually provide easy access to the venous system. Central veins are deeper and located closer to the heart. A CVAD is a special catheter with a tip that ends in a large vessel, i.e., the superior vena cava near the heart. This chapter primarily focuses on short peripheral catheters. The definition of the various types of CVADs, or the central vein access device, are discussed briefly at the end of this chapter. C. Initiating peripheral intravenous therapy under procedures in your online resources for a detailed explanation of how to initiate a peripheral IV cannula. Nursing process for the patient receiving intravenous therapy. IV therapy is a medical intervention. The nurse is responsible for appropriate assessment, monitoring, documentation, and reporting related to the therapeutic goals. Data collection. Some institutions require assessment as often as every hour. An INS position paper provides some guidance on the frequency of site assessment, including the following recommendations. Assess at least every 4 hours for patients not getting an irritant or vesicant and who are alert and oriented. Assess every 2 hours for critically ill patients and adult patients who have cognitive sensory deficits, are receiving sedative medications, or are unable to notify the nurse of any problems, or have an IV placed in a joint area or external jugular vein. And you are going to assess every hour for pediatric or neonatal patients. Assessment should be systematic and thorough. It should include physiological and psychosocial data, critical laboratory values, allergies and environmental issues, and presence of adverse reactions or complications related to infusion therapy. Of course, older adults are at increased risk for complications, making careful assessment essential. So we have a purple box that is going to go over some of those gerontological issues. So care of the older adult receiving intravenous therapy. When an older adult patient is receiving IV fluids, regularly assess the patient for potential fluid volume excess. So symptoms of fluid volume excess include the following. Okay, elevated blood pressure, increasing weight. So a weight gain of 2.2 pounds is equal to the retention of 1 liter of body water. So we're also going to watch for peripheral edema, a full bounding pulse, shallow, rapid respirations. You're going to look for jugular venous distension, increased urine output, development of moist crackles in the lungs, and cyanosis. That's a late symptom of pulmonary edema. Okay, so again, these are all symptoms of fluid volume excess in patients receiving IV therapy. So if we see this, what do? Okay, well, if the above signs are present, you want to immediately notify the registered nurse or turn down the IV to a minimum drip rate, which would be like 1 ml per minute. Do not discontinue the IV because the healthcare provider may want to order IV diuretics. That would help to relieve some of this excess fluid volume. That's not our decision. That's a decision of the healthcare provider. So we do need to notify the RN or the healthcare provider so that a decision can be made on what action to take. So we do want to position the patient to maximize lung expansion. So that's going to be high Fowlers or semi-Fowlers. We'll want to, so these are what we're going to do if they have too much fluid, but we have to continue the drip, right? You're going to maybe apply oxygen by mask or nasal cannula if it's indicated and per the institution guidelines. Of course, we're going to closely monitor the patient's vital signs, their level of consciousness, and the oxygen saturation along with their fluid outputs. We will assist the healthcare provider or the RN with IV push administration of a diuretic medication, such as furosemide if ordered, which I think that's Lasix. Okay, so physical assessments such as daily weights and measurement of intake and output help determine whether the patient is retaining too much fluid. Skin turgor, mucous membrane moisture, vital signs, and level of consciousness may also indicate hydration status. New onset of fine crackles in the lungs can indicate fluid retention. Table 7.1 lists other symptoms of complications along with prevention and treatment strategies. Inspect the insertion site for redness or swelling. Evaluate the integrity of the dressing and document your findings. Inspect the tubing to ensure tight connections and the absence of kinks or defects. Inspect the solution container and compare it with the HCP's order for type, amount, and rate, and you will report abnormal findings to the RN or the healthcare provider. So the picture shows some of the veins that we might be using for peripheral IV access. There we go. So Mr. Rick has blood backed up on his IV tubing, his intravenous tubing. When you open the clamp to increase flow, nothing happens. What should you do? So I'm going to go to the back of the chapter and see what they said for Mr. Rick on critical thinking. Okay, so Mr. Rick, your patient's IV line is likely clotted. If it has been so for a long time, it's not going to be salvageable. So don't flush it because doing so can dislodge the clot into circulation. You'll want to discontinue the IV line and insert a new cannula. So Mr. Gonzalez, oh, that's a different one. Okay, let's keep on going then. So nursing, diagnosis, planning, and implementation. Priority nursing diagnosis for IV-related issues may include the following: fluid volume excess related to IV fluid administration. Expected outcome: the patient will have stable fluid balance as evidenced by stable vital signs, stable weight, and clear lung sounds. See gerontological issues. Another nursing diagnosis could be fear related to insertion of IV cannula. Expected outcome: the patient will have minimal fear as evidenced by cooperation with the procedure and verbalizing minimal fear. So you'll want to explain the IV therapy, e.g. the rationale for therapy, the insertion procedure, care of the IV, and the importance of reporting pain, swelling, or pump alarm to the patient. So lack of knowledge is associated with fear. So it's normal to fear the insertion of a needle. So we have to attempt to assuage their fears to a manageable level by explaining what we're doing and why to help reduce their fears. Impaired physical mobility related to placement and maintenance of IV cannula. So the expected outcome is that the patient will maintain mobility as evidenced by a full range of motion and avoidance of complications related to immobility. So we want them to be able to be mobile. Avoid insertion site close to joints if at all possible, because joint areas are mobile, making it difficult to maintain an intact site. If you must use a mobile site, such as antecubital fossa or the wrist area, immobilize the joint with an arm board or other immobilizer to reduce cannula movement. Remember to get an order for this, because this is considered a restraint. So this is where your institution policies will be important too, I think. If the site must be wrapped to protect from movement, be sure to leave the insertion site visible or removing wrapping to view the site according to the agency policy. The site must be visualized for complications, even if it's covered. So we're going to have to uncover it. It's so important that we visually monitor for these complications. And then you're going to want to assist the patient with activities of daily living, because the patient may have difficulty with these activities if their movement is limited, because we want to make sure that the IV remains patent for them. Okay, so table 7.1 goes into all the complications listed on the screen and several more. And I put a lot of asterisks on this. This is page 78 and 79 of my book. And so I think that we are going to be responsible for knowing all of these things, which is kind of nice because it's listing what the complication is, such as hematoma, what the signs and symptoms are. In this case, for hematoma, you'd be looking for ecchymosis, which I think is redness, swelling, an inability to advance the cannula, and resistance during flushing. So they also list how to prevent the hematoma, which would be one of the ways to use indirect method of venipuncture. Choose the smallest cannula appropriate and apply a tourniquet just before the venipuncture. And then there are some treatments if there's a hematoma. You'll want to remove the cannula, apply pressure with a 2-inch by 2-inch gauze, and elevate the extremity and apply a cold compress. So they have the complication, the signs and symptoms that we need to watch for, the prevention and the treatment for the hematoma, thrombosis, phlebitis, for infiltration or extravasation, for local infection, for venous spasm, for septicemia, which is pretty long, which is really important for us to be able to identify in patients because it can become very serious. Circulatory overload. They also talk about venous air embolism and speed shock. So the last three that I mentioned, the circulatory overload, the venous air embolism, and speed shock, for the treatment, they all three of those say in all caps, call for help, with an exclamation point at the end. For circulatory overload, you're going to want to decrease the IV flow rate, place the patient in high Fowler position, keep them warm, monitor their vital signs, give them some oxygen, maybe use an EID with dose error reduction system and an anti-free flow administration set, and of course, notify the RN /HCP. For venous air embolism, which the signs and symptoms are going to be lightheadedness, dyspnea, Cyanosis, so that's dyspnea is irregular breathing. Cyanosis is when they're turning blue. Tachypnea, which would be rapid breathing, expiratory wheezes and cough. Also chest pain, hypotension, and changes in mental status. Those are all signs and symptoms of a venous air embolism. And if that occurs, you're going to want to call for help, place the patient in a Trendelenburg position on their left side, administer oxygen, and monitor the vital signs. So very similar to the last one, except that we, are going to put them on their side, left side. For speed shock, now speed shock, the signs and symptoms are dizziness, facial and neck flushing, pounding headache, tightness in the chest, hypotension, an irregular pulse, and progression of the shock. So you're going to want to call for help, get your RN or your HCP, stop the infusion immediately, and give an antidote if it's appropriate, or resuscitation medications as ordered. I'm going to go on to page 80. So there's always a risk for infection related to the broken skin or traumatized tissue because we have to break the skin to get the needle in for the IV. So the expected outcome is that the patient will be free from infection as evidenced by no redness, swelling, or purulence at the IV insertion site, no fever, and normal white cell counts. So you're going to watch for signs of infection so that the IV can be removed and or the site rotated and infection treated quickly if it occurs. Use good hand hygiene and strict aseptic techniques during cannula insertion and maintenance care to prevent the introduction of pathogens. You're going to change the tubing and solutions regularly according to the agency policy to prevent growth of microorganisms. And change or remove the cannula when clinically indicated to reduce prolonged risk. Okay, so evaluation. Now the RN is responsible for evaluation of outcomes and thus monitors the patient for evidence that the goals of therapy are being met and that complications are avoided. The LPN collects data that can contribute to the evaluation. For example, if antibiotic therapy is administered, monitor for signs that the infection is resolving. If IV therapy is ordered to correct dehydration, monitor for improved fluid balance, and document all findings and report them to the RN. Okay, another Be Safe, Be Vigilant box. To prevent infection, the Infusion Nurses Society Standards of Practice state, in addition to routine changes, the administration set the tubing is changed whenever the peripheral catheter site is changed or when a new central vascular access device, a CVAD, is placed. The INS also instructs clinicians to replace or remove any peripheral IV cannula placed in an emergency situation within 48 hours of the insertion or as soon as possible or practical. All right, so let's talk about some of these complications of IV therapy. Complications of infusion therapy fall into two categories: local and systemic. Any complications or unusual incident should be reported to the RN or HCP. A quality improvement report should be prepared according to institution policy. The most common peripheral local complications are hematoma, phlebitis or thrombophlebitis, infiltration, extravasation, and nerve injury. The INS lists the dorsal hand, radial wrist, and inner wrist as sites to avoid to prevent permanent nerve injury. Systemic complications can be serious. They include circulatory overload, septicemia, venous air embolism, and speed shock, which is a sudden reaction due to medication that's delivered too quickly because the body just becomes overwhelmed and goes into shock. So the nurse delivering infusion therapy must be knowledgeable in preventing, recognizing, and treating all complications of IV therapy. See Table 7.1 for complications prevention and related care. Okay, we've got a critical thinking now. So Mrs. Gonzalez is receiving 5% dextrose in water at 83 milliliters per hour. 1 hour after the infusion starts, she reports pain at the site. The site is cool to the touch and swollen, and the infusion rate is sluggish. What might be happening? What additional data should you collect? What action should you take? And how should you document your findings? What other team members could be consulted to help in this situation? All right, so let's think about Mrs. Gonzalez here. For Mrs. Gonzalez, so the IV fluid may be leaking at the insertion site and flowing into the subcutaneous tissue, a problem known as infiltration or extravasation, depending on the type of drug infusing. So this is important to remember because the symptom is that the site is cool to the touch and swollen. She's got some pain, and the infusion is kind of slow, okay? So the coolness is going to indicate to us this infiltration has occurred or extravasation. So the second question was, what additional data should you collect? Well, you need to consider whether the pain could be caused by the buildup of fluid under the skin because we're seeing some swelling. And so you can compare the insertion site with the opposite limb. Number 3, what action should you take? If the IV solution has infiltrated, which we suspect, stop the infusion, disconnect the cannula, and restart the cannula at a new site. Number 4 was, well, how should you document your findings? So in this case, you're going to document the following. Patient reports pain at IV site in right arm. Area is cool to touch and edematous in a 4.5 centimeter area around the site. Flow rate, flow rate sluggish. Infusion discontinued. IV restarted in left arm with 22 gauge cannula with good blood return. Infusing well with no signs of infiltration. All right, and so you're also going to be reaching out to the registered nurse or the IV therapy nurse as a good resource to help in the situation. So, central venous access devices. The role of the LPN in CVA care in most states is limited to assisting the RN with assessments. Therefore, it's important for you to be familiar with the different CVADs so that you can recognize and report problems. Central venous catheter tips terminate in the superior vena cava near the heart. So it's right here, right before the blood enters the heart. They are used when peripheral sites are inadequate. CVADs can be used to deliver all types of solutions, medications, blood, or blood products when continuous infusion is required. They are also beneficial when irritant or vesicant medication must be delivered into a large vein. CVADs include tunneled and non-tunneled catheters, peripherally inserted central catheters, and implanted ports. These devices can have 1, 2, or 3 lumens in the catheter or more port chambers. Each lumen of a multi-lumen device exit the site in a separate line called a tail. Multi-lumen devices allow simultaneous administration of solutions while preventing mixing of incompatible solutions. Be careful not to confuse a central catheter with a dialysis catheter. Dialysis catheters should be used only for dialysis and not for IV therapy. Also, they should be accessed only by HCPs or specially trained dialysis nurses. If you are not sure what type of catheter your patient has, be sure to ask the RN or HCP. Non-tunneled central catheter. A non-tunneled central catheter, central vein access device, CVAD, is inserted by a healthcare professional into the jugular, subclavian, or femoral vein. After insertion, correct placement is determined by X-ray before the catheter is used. These short-term CVADs may remain in place up to several weeks, but placement time is typically about 7 days. Non-tunneled CVADs can be inserted at the bedside or in an outpatient setting, and they are cost-effective for short-term CAV. Non-tunneled CVADs can be used for many purposes and can be easily exchanged. However, there are disadvantages such as ongoing maintenance care and body image issues. Tunneled catheters, okay? Tunneled catheters, anyway, there's one. Okay, tunneled catheters are used when venous access is needed for months to years. These catheters are typically composed of polymeric silicone with a Dacron polyester cuff. The cuff not only anchors the catheter in place subcutaneously, but also provides a barrier to prevent bacteria from migrating to the tip of the catheter. The catheter tip is commonly placed in the superior vena cava, which would be shown, I believe, well, there's the superior vena cava. I think they're showing it going in. Okay, so it's actually coming all the way down here on this picture. But anyway, let me see if I can make it bigger still. That might help. So they're actually inserting it there, and then it's going into the heart directly. This other figure is showing that it's inserted, well, they've inserted along the basilic vein. Okay. Still, it's getting into the superior vena cava, and then this one is also inserted. This is showing a triple lumen catheter that they're inserting via incision here, and then it's going all the way into the heart. So you can see why they're requiring an X-ray so they can make sure that this is really down here and not somewhere else. Okay, so advantages of a tunnel catheter are that a break or tear in the catheter is easy to repair, and they can be used for many purposes. The disadvantages include concerns such as weekly site care, the cost of the maintenance supplies, and the effect on the patient's body image. Because I'm sure this can get in the way of their clothing and stuff. Peripherally inserted central catheter. A peripherally inserted central catheter, a PICC or PIC, is a long catheter that is inserted in the arm and terminates in the central vascular. So they're showing that right here in this picture. A PIC can be tunneled or non-tunneled. This device is used when therapy will last more than 2 weeks or if the medication is too caustic for peripheral administration. Specially trained RNs can insert PICC lines, and they can be left in place for long periods, minimizing the trauma of frequent IV insertions. Consult with the healthcare professional for a PICC order if long-term therapy is anticipated. It is important to follow the manufacturer's recommended guidelines for flushing the catheter and to be aware of your institution's PICC policy. A trained RN removes a PICC catheter when therapy is terminated. An LPN may assist the RN with this procedure if the State Nurse Practice Act permits. Ports. Looking for something on ports on here, but I'm not seeing it, so let me go right back up to this one. Okay. A port is a reservoir that is surgically implanted into a pocket created under the skin, usually in the upper chest. A catheter is attached to the reservoir and is tunneled under the skin into a central vein, such as the superior vena cava. An advantage of a port is that when not in use, a dressing is not required. It can also be flushed and left unused for long periods. When the port is not in use, the patient can swim and shower without risk of contaminating the site. Ports come in a variety of sizes and styles, and they are now being placed in many areas of the body. Ports are suitable for long-term therapy. They can be used to administer all types of medication, including chemotherapeutic agents and antibiotics that are toxic to tissues. In addition, power injectable ports can be used for radiology, imaging, and procedures. So what that means is that there's a contrast media that's needed sometimes, and the contrast media, which can be very hard on the kidneys, by the way, are often attached to a power injectable port. So ports are usually accessed only by specially trained RNs. They require the use of non-coring needles that are specifically designed for port access and infusions. There's another Be Safe, Be Vigilant box. Implement evidence-based practices to prevent central line associated bloodstream infections. This requirement covers short-term and long-term central venous catheters and PICC lines, peripheral inserted central catheters, per the 2018 National Patient Safety Goals. Vascular catheter-related infections are considered never events because they can be prevented and should never occur. Hospitals will not be paid by Medicare for such infections acquired during hospitalizations. So as nurses, we are the ones that are responsible for preventing that. Other therapies, parenteral nutrition. Parenteral nutrition is complete IV nutrition that is administered to patients who cannot take adequate nutrients via enteral route by feeding or by tube feeding, by mouth or by tube feeding. And I am on page 82. Parenteral nutrition, or PN, may be used to promote nutrition for wound healing, to help a patient achieve optimal weight before surgery, or to avoid malnutrition from chronic disease or after surgery. Patients with ulcerative colitis, trauma, or cancer cachexia, which is wasting syndrome, are candidates for PN, or parenteral nutrition. Every effort should be made to return a patient on PN to oral or tube feedings as soon as possible. Parenteral nutrition provides and maintains the essential nutrients required by the body. Solutions contain carbohydrates, amino acids, lipid emulsions, electrolytes, trace elements, and vitamins in varied amounts according to the patient's needs. Due to the components in PN, compatibility issues must be considered. Therefore, medications should not be piggybacked directly into PN solutions. There's already enough in there, okay? PN requires filtration and an EID for administration. A 0.22 micron filter is required for lipid-free parenteral nutrition. PN solutions with lipids must have a 1.2 micron filter. So if you have anything smaller than that, the lipids are not going to get through because they're pretty large. So you need to ensure you have the right size filter. And patients receiving PN in the home setting may use an ambulatory infusion device to allow for more mobility. Initial assessment includes the patient's height, weight, nutritional status, and current laboratory values. Because of the high glucose concentration of PN, the patient is at risk for infection and blood glucose disturbances. Insulin therapy may be necessary during PN administration. Ongoing assessments include blood glucose levels according to the institution policy and monitoring for signs and symptoms of infection, hyperglycemia and hypoglycemia. When PN therapy is begun, the rate is increased gradually to the prescribed rate to help prevent hyperglycemia. When nutritional solutions contain concentrations exceeding 10% dextrose or 5% protein, they must be administered via a CVAD. Okay, when the concentrations are less than 10% dextrose or 5% protein, they may be administered through a peripheral vein. And this is referred to as peripheral parenteral nutrition, PPN. PPN is a short-term intervention because it does not provide adequate nutrition over an extended period. Some states allow LPNs to initiate PPN, and I don't know if Massachusetts does. The entire healthcare team must be involved in PN or PPN therapy. The pharmacist, dietitian, HCP, and nurse communicate in a team conference to discuss the assessment, plan, and outcome criteria. Many institutions have nutrition teams that assess the appropriateness of PN or PPN for individual patients. Okay, home intravenous therapy. As healthcare costs continue to rise, patients are using more alternatives to hospitalization. Subacute care, skilled nursing care in long-term care facilities, and home health care are growing. Home IV therapy allows many patients the benefit of early discharge and the ability to receive health care in the privacy and comfort of their own homes. Most patients requiring home infusion therapy will have a CVAD rather than a PIV. Some home health care agencies employ nurses to instruct patients and their families in the administration of home IV therapy. See home health hints. Before discharge, the patient's benefits for reimbursement for home health care should be verified. Home IV antibiotic therapy is becoming the method of choice for long-term treatment of certain infections, including bacterial endocarditis, osteomyelitis, and septic arthritis. Other patients with various diseases may choose to receive PN, chemotherapy, or IV pain medications at home. The the health team can assess patients and their families for their ability to manage home IV therapy, cleanliness of the home environment, and the ability to safely store equipment in the home must be determined before discharge. Okay, so some of the home health hints. Before discharge, obtain a referral for a home health nurse to coordinate IV therapy at home. And once the patient has selected a home healthcare agency, coordinate discharge from the hospital with the agency so that no IV doses will be missed. And provide home healthcare agency contact information to the patient. At home, instruct the patient to keep the IV site dry. If showering is permitted, instruct the patient to cover the IV with plastic, such as a grocery bag, and seal with tape on both ends to prevent water from entering the site. Assist the patient and caregiver to identify a safe place to store supplies. Note that some solutions or medications require refrigeration. Remind the patient to remove IV solution from the refrigerator 30 minutes prior to the arrival of the home healthcare nurse. Hypodermocliasis. An alternative option for the administration of medications or fluids is subcutaneous infusion or hypodermocliasis. This is becoming a more common route in pediatrics, palliative care, and hospice settings, as well as for the elderly. Isotonic fluids and limited medications can be administered via this route. Hypodermocliasis is recognized as a safe, low-risk, cost-effective route to treat dehydration and for use in patients with poor vein quality. Hypodermocliasis infusions were common in the 1950s, but complications and adverse reaction reports reduced the use of this infusion. Today, pharmacological companies are developing subcutaneous formulations of medications that will improve response, physiologic effect, and patient compliance. With new formulations, antimemetics, monoclonal antibodies, immunoglobulins, pain medications, and antibiotics are being studied as emerging therapies to be given via the subcutaneous route. To access the subcutaneous route, a needle or catheter is placed below the dermis and epidermis in the fatty tissue. Fluid volume is limited at a site. To reduce the risk of edema, the administration rate is approximately 1 milliliter per minute. Fluids and medications administered via this route will pass through the extracellular matrix to be absorbed by the capillaries and the lymphatic system. Locations for subcutaneous access include the abdomen, thighs, upper arms, chest, and scapula area. Some advantages are slow absorption rate, decreased severity of infection, and minimal training. Site assessment and monitoring are crucial to limit complications. Patient education should include reporting pain, redness, swelling, or leaking at the site. Patients and caregivers can be taught how to obtain access and infuse the medications. Disadvantages include the risk of edema, drug choice limitation, and less interaction with the home health nurse due to in-home self-administration. So, reflections on Mrs. Brown. Thinking again about Mrs. Brown in the scenario at the beginning of this chapter, okay, she will need monitoring of intake and output, daily weights, and close monitoring of her IV infusion. You should anticipate that serum electrolytes, blood urea nitrogen, and creatinine laboratory studies will be ordered. When initiating the infusion, use care in application of a tourniquet because older skin is thin and bruising can occur. Choose a number 20 or 22 gauge cannula to start the infusion. Once it is started, continue to monitor weights and lung sounds because older patients can quickly go from fluid depletion to fluid overload. And remember, so we're talking about a 20 or 22 gauge cannula, which is the needle. And as a reminder, the smaller the number on the cannula size, the larger the size of the needle. So a size 14 is a pretty big needle, whereas a 22 gauge is actually going to be a smaller needle than the 20 gauge. And I think that the smallest, it goes up to like 28 or maybe 33 for really, really tiny needles. Okay, so let me advance here. So here's a review question. How long should an area be cleaned with alcohol or chlorhexidine prior to initiating an IV cannula? And the answer, I don't remember them saying 30 or 60 seconds. I thought, well, it is 30 seconds actually. Okay, 30 seconds. That's a long time. Okay. Which patient assessment findings indicates fluid excess? Warmth at the IV site, an irregular pulse, profuse sweating, or crackles in the lungs? The answer would be crackles in the lungs. That's going to indicate a fluid excess. Which vein distension technique is best for the patient with fragile veins? A simple tourniquet, multiple tourniquet technique, a blood pressure cuff, or avoid the use of a tourniquet? So I'm thinking we're going to avoid the use of a tourniquet and just go with a blood pressure cuff. That's the answer. So if you have a patient with fragile veins, you can achieve the results you need with just a blood pressure cuff instead of a tourniquet. So what is the best intervention to correct a clotted IV cannula? Okay, if it is clotted, number one, flush it with heparin, flush it with haline, milk the IV tubing, or remove and replace the cannula. Now, if you know there's a clot, you don't want to flush it while it's in the patient, or you are going to be causing the clot to advance and enter the patient, which can be a problem. So I'm going to say that you need to remove and replace the cannula, which is correct. So if you know there's a clot, you better just take the whole thing out. That's the last slide. Now, it is 9:30, and there are 8 questions at the end of my book, but also I was thinking that we might want to take a look at what is on the ATI site, but because I've had difficulty in recording the sound when I'm playing things on my computer via Zoom, I don't want to do that on this particular chapter. So I'm going to go ahead and end this one. The review questions are on page 84. In my book, they did include the answers. So hopefully they did in yours as well. And I thank you for joining me, and we will see you next time.